Okay, so MyHealth is a classically what we think of as a health information exchange organization, in that we established a community level governance. We brought hospitals, clinics, pharmacies, you name it, stakeholders in healthcare, payers, government agencies into the room in 2009 and said, we've got a problem with health in our state and costs, and it's not just a health issue, it's an economic development issue as well. What do we do to remedy this? And the plan that emerged was MyHealth. And so this is MyHealth as it stood. I don't know, it's probably a 2-year-old slide now, but about 1,000 locations statewide at that time, probably a time and a half that now, of all kinds of organizations, not just hospitals and clinics, but behavioral health, pharmacies, and pharmacies are critical because we get the dispense data from those pharmacies as the medications are dispensed, for example. Social service agencies now are coming on as a part of the Accountable Health Communities program, which I'll talk more about in a moment. So we're starting to really think about this as a person-centric network rather than even a healthcare-centric network because we're sharing data across other disciplines as well. Okay, so these are the patients who have information in the MyHealth system. This is their home address. Okay, so what this shows, and this is over about a 5-year time span, this shows that patients from about 70% of U.S. zip codes have at some time or another, at least one person in that zip code has received health care in Oklahoma. And we know Oklahoma is not a center for medical tourism, right? We have noodling, and if you don't know what that is, ask me at the break. But we don't actually have medical tourism to any degree that I'm aware of. And yet, look how scattered the patients are that receive care there. So imagine what Texas or New York or Minnesota looks like with these sort of centers that people travel great distances to get care from. So that's one of the challenges that we face when we start to think about patient-centric measurement is how do we put all that together in one picture so that we're getting the most comprehensive view of what's going on with a patient no matter where they got their care. Now, the work I do sort of has me keep feet in different camps. Like I do a lot of work with the health information exchange organizations whose primary focus is just getting the data together and making a comprehensive chart for the patient. And that sort of is the extent of what they're thinking about. And then I do some work with the groups that are trying to do sort of operational analytics to help make ACOs and other payment models work well. And then I do work in the measurement side and have conversations with folks like this group about, well, how do we actually measure to know whether improvement is happening or not? But I actually think that it's important to understand all three of those worlds in order to have a comprehensive approach for the way health and healthcare should work. And so, I'm sort of rooting this conversation with you, knowing that the focus is measurement, in the bigger picture of, well, what are the motivations for doctors and hospitals and everyone else in healthcare today, and how do we make sure that what we measure is both not in the way and at the same time can be thought of as dispassionate, meaning the data we gather is not sort of, can't be biased in any direction by the folks who are being measured, and also is actually meaningful and valuable to reducing costs and improving quality. And so, as you well know, value-based payment models are here to stay. The MACRA is out there, and it's been pretty widely adopted by commercial payers. We have it extensively in Oklahoma, and I think it was 1987 before we got Vans shoes in Oklahoma. So I'm pretty sure that that it's in a lot of other places too. We tend to be behind the curve. And so given that, you've got a lot of providers who've got a foot in the fee-for-service world and a foot in the value-based payment world and the risk-taking world, and they're really struggling with what to do with that. And to the extent that I have a lot of clinics who are eager to run faster and faster and faster down the value-based payment model road, but the CFO that runs the health system they work in is really only thinking about the hospital beds and how filled those beds are, regardless of what the quality measures are around the performance in those beds. So given that, it's important to understand the world of a provider, and this is what a doctor in Oklahoma has to be thinking about, are all these different programs, some of them federal, some of them local, some of them philanthropic, that are coming and demanding their attention on various quality efforts for early childhood or for for health homes there. You see mental health, behavioral health, You see ACOs. You see we're a CPC plus, that's Comprehensive Primary Care Plus state. And then, of course, there's MIPS and whatever other alternative payment models come along. And all of these things demand attention. And then if you factor in the fact that every provider gets a different contract, generally speaking, from every payer that wants them to focus on a different set of measures or a different set of activities, you can start to see why the providers are just tapping out. I mean, there's really no way to do anything meaningful unless we coordinate these efforts. And so I think it was said in the session I was in earlier just how great the idea behind the Comprehensive Primary Care Initiative was, because in that model, I think we got a slide on it here. Yeah, so in that model of the Comprehensive Primary Care Initiative, it's a multi-payer model. And so we had the experience starting in 2012 of being selected as a region to test out this Comprehensive Primary Care Initiative model. And in it, in that experience, we came up with 8 things we thought of as being critically important to being successful in that model. And you'll see your area really is down around, I would say, everything from 3 through, no, actually it's 2 through 7 are really central to the measurement world, and that's what I want to emphasize in this conversation. But I will tell you that if you're trying to figure out how to get folks to adopt measures, make sure that United and Blue Cross and Medicare and Medicaid in the state, all and you know, Aetna and whatever their major payers are, have all agreed on the same measures to pursue. Because when that happens, 90% of my patients are I'm being measured on doing the same thing for 90% of my patients. I can focus on those measures and do something about it. And the Comprehensive Primary Care Initiative had that baked in, right? So it was the 4 major payers in Oklahoma. We constrained it just to northeast Oklahoma up there. And it was 68 practices, 265 doctors, around 180,000 to 200,000 patients in the program across those 4 payers. It was a 4-year program. And in the program, Medicare paid up front care management fees, and the other payers did as well. And it turned out that when they leveraged one another, they each could pay a little less to make a massive difference in the staffing and the available workforce in these clinics, so that all of these practices now had a care manager focused on between visit care, on closing gaps in care, on the quality measures, and thinking about things other than just rooming patients and streeting them, right? And that was fundamentally critical to it. And so in that program, for some reason, and I propose that in part it's because we had done the background work starting in 2009, but for some reason Oklahoma did better than all the other regions in the project. And this is year 1, but I can tell you that every year since year 1, Oklahoma's had about that same amount of performance. And actually I can show you. Our Medicare Advantage plan that participated saved 14% over a 2-year window, with an almost 50% reduction in high-cost imaging, among the other savings points. This is sort of the big picture, and everywhere there's a tilde, I'll tell you, I couldn't find the actual number, but I was able to get to the estimate and back into it. But what you see there are, if you look at the total line across the 4-year program, 110 million, close to that in gross savings, about 65 million net savings after all the shared savings and program costs, and it's net somewhere around 5% overall in Oklahoma. But interestingly, the providers actually came out way ahead as well. They collected $21 million in shared savings bonuses on top of the $56 million in care management fees that they got. So what we had here was a model which was a win-win-win, right? Because the payer won with decreased costs, providers won with increased revenues, but they got those revenues by doing the right things. And of course, the patients spent less time in the hospital because 30-day readmissions went down, all-cause admissions went down, ER utilization was contained, and they instead got to go to work and have a PCP that they visited when they were sick. So we think that was a pretty big win, and the employers that participated for the commercial payers agreed. They had a great experience as well, and in fact, they funded their own care management fees and got to keep their own share of the shared savings with the practices, to the extent that now we have employers who basically have purchased their commercial plan as an ASO and said, hey, we'll do no copay for a practice that's in this program. So they're steering patients into these programs. And I would submit to you that that's really what you want to happen with a payment and quality model, with a value assessment model that's out there. And so given that, these are some of the lessons we've learned, and what we're doing now to try and reinforce it. As I mentioned, CPC Plus is out there now. It's in a lot of states. I think it's maybe 20 states now that are in the CPC Plus program. And we have 181 practices in Oklahoma. Ohio has like 600 practices in it. So there are a lot of practices engaged in the model. But it touches hospitals as well. And if other places are like Oklahoma, a good percentage of our primary care providers are actually owned by health systems. So this was a dance we had to play, and I thought it was going to tank our ability to be successful in this model, but it turned out that the primary care providers were able to drive enough of savings to make a difference, despite the pressure from the CFO. All right, so the second thing that was critically important, now we're getting into things you might have some control over, is having the correct scope of data, and that means patient-centric and community-wide. Not just in one vertical. And here's the way I conceptualize that. So claims data we're all familiar with. We think of it as being a mile wide but only an inch deep, right? It's got pretty much the story on everything that went on with the patients, but it doesn't have the actual hemoglobin A1C result or the actual blood pressure measure, right? And then, of course, there's the patient out of pocket that we have a hard time getting our arms around, everybody except Visa, I mean. And then there's the clinical data itself, right, in a clinic. And we think of that as deeper and richer information, and we've all been creating measures to use that EHR data. But in reality, real patients look like this, right? Their data crosses a bunch of different EHRs. And would you agree with me that the sicker the patient, the more databases they're going to appear in? Because they're going to get care from a specialist number 1 and specialist number 2 and specialist number 3. And then would you also agree with me that when you have a situation like that, the validity of any one of these organizations' quality measures goes down because there's a greater likelihood that the real data is somewhere else? So then we add in all these other important data sets to the mix, and you can see that from my perspective as a methodologist, which I'm not really, but sometimes I pretend to be, tells me I've got to have this comprehensive data set to draw any conclusions from, and I'll show you in a minute why. Okay, so come on, clicker. So we actually, it's not good enough just to hypothesize this. We actually went in and quantified this result. And this is now about a year old, and I will tell you it's been trending up at a pretty rapid clip. But this is a histogram that shows how many different EHR databases patients have their data in. Because remember, as an HIE, we have a master person index, and we resolve identity across organizations. And so what you see here is that at that point, 43% of all people in Oklahoma, healthy, sick, everybody we were aware of, had data in 2 or more EHR systems. And I can tell you that when I looked a month later, it was already at 47%. So it climbs as you add more data sources to the mix. Now, this sort of correlates with something that MyFam published that showed that the average primary care provider was having to coordinate care with 225 other providers. Right? That's 220, just me as a PCP have 225 other people who are also taking care of my patients. And that's from the claims side where you can determine that pretty easily. And worse than that, they're not 225 people in my health system. They're in 117 other organizations. So there's no flow of data between us. And so now we've got a real fragmentation problem we've got to deal with. Now, if we narrow into patients who have diabetes, let's just take a chronic disease, the classic chronic disease, now the number jumps to 2/3 of all people in Oklahoma, right? So that means that 2/3 of the time when I walk in the room to see a patient, they're going to have information somewhere else that I need to be aware of, right? And if I measure quality on the data I have in my system, it undercuts the confidence interval on that too. So then we looked and said, well, what about people who've ever been to a health system? Because we have people in our data that just have been to the pharmacy, for example. If we look at people who've been to a health system, this number climbs quite a bit. 71% have data in 2 or more places. And with diabetes, it's 86% have data in 2 or more places. So none of this probably surprises you, but it does have, I think, dramatic implications for the way we think about measurement, especially because, let's see if this rings true with you or not. I think if we project ourselves a few years down the road, and value-based payment models have been out there, and we've been measuring quality for a while, and if we are able to demonstrate that quality improves and costs don't change, and that the ultimate outcomes of quality of life or duration of life aren't improved, people are going to quit believing these quality measures because they won't have any correlation with what we actually saw. So that's why I'm so so determined to figure out how we measure in the most valid way to make sure that it will be a predictor of cost savings going forward. So anyway, if we take this map then, and we realize the fact that, of course, 20% of patients change insurers on an annual basis. You got 20% churn in the payer side. And from a payer's perspective, it's as if people die and are born again, right? They just disappear from your database and appear in someone else's database, and you start all over on risk stratification and so on from that age. So we were able to, by establishing a governance first, we were able to have both the payers and the providers around the table. And the payers and the providers agreed that what they wanted ultimately was a healthier population and a better quality of life for people in our communities. And then we began to talk through, well, what does it mean to put this data together in one big picture, and what are the value propositions for doing so? And so the payers all said, well, we want to do value-based payment models, but we're just not sure what to do with these quality measures coming from the various practices because they're all so different. The denominators are all over the place, the numerators are all over the place, and basically it's self-reported, right? I mean, they just type into a spreadsheet and send it to us, the numbers. I mean, except for Medicare where we type it in there or we submit it. And so the payers had a difficult time, at least the payers on our side of the Mississippi had a difficult time with that approach. But the providers, on the other hand, who said, well, the claims data isn't a good thing to measure us with anyway. You're going to want clinical data to do that with. We've got it, but we don't trust your claims data for measurement either. And so we had this issue where we had the two parties sitting across the table from one another trying to negotiate a contract, and there was not enough trust in what either one was going to present. And about the same time, there was a big ACO project in Chicago where the payer and the provider group got together. They agreed on the quality measures, and they agreed on the performance targets. And then the provider went away and delivered care, the payer went away and paid claims. When they came back together at the end of whatever the measurement period was, the provider came in the room expecting a multi-million-dollar bonus for their performance. And the payer came in the room expecting a multi-million-dollar penalty. And why was that? Well, it turns out the payer was measuring in the claims data and the provider was measuring in their clinical data, right? And there's some fundamental differences there. In addition to what variables are present, the people in the two data sets were different. The provider was measuring quality for everybody they took care of. The payer was measuring the quality of service delivered just for the people they had attributed to that provider. So where'd they wind up? They wound up in arbitration. I don't know if they ever actually went to court or not, but that doesn't sound to me like a very productive, functional system for paying for quality or value if you're just going to wind up in court every time, right? They had the same measures agreed on and even the same benchmarks, but they failed to agree on the data set. So we basically came up with an idea, or highlight an idea, come on, clicker, there we go, that we call it the trusted third-party approach. I sort of alluded to it yesterday in my comments on the panel, and the notion here is that the payer sends us the claims data, and the provider sends us the clinical data, and we use the master person index to resolve that into one master record for each individual person, right? And then as the trusted third party, we can tell either side, you know, quality of the data is bad on this measure, we got to improve it, and we can provide advice. They contract with one another just like they always have, but the contract points to us as the unit, as the trusted third party that they're going to get the result from, right? And so we do these analyses, and of course, they're both on our board of directors. We're nonprofits, so they both own and operate us, basically. And they tell us which measures to focus on and what benchmarks they want to use and so forth. And so we can do the payer-specific measures, we can, claims-based measures, we can do the clinical-based measures, and now we're beginning to do hybrid measures where we use the best of both worlds to put in there. So everybody can probably quickly shout out a measure that is really difficult for clinicians to get, like, say, diabetic eye exams, right? I mean, every provider I've ever known hates that measure. Why is it so hard? Because it's data coming from another system, right? The people doing the eye exams are in a whole other organization from me. And so what's the answer in many clinical settings now? They buy a device to do the eye exams for them, right? I mean, sort of replacing the optometrist with his device in the clinic. It's something else they can bill for, of course. But then the rest of eye care just doesn't happen because they didn't go see an optometrist. So that kind of situation is the kind of thing that we're trying to prevent from happening in this data. And so we have the claims on the eye exams, and we have the few documented physical exams that included that eye exam that come in through the data, and we've partnered with the optometrists to get a feed from them. So in that way, we've created a comprehensive picture of the information. And so the value can be assessed and the money can move. And I'll tell you a little bit more about the mechanics of actually that moment when somebody gets a check and someone else doesn't get a check, because that's really relevant to this discussion. So essentially what we've got is a health information exchange and a voluntary all-payer claims database. And the fact that it's voluntary is important because I live in the reddest state in the union, and we're not about to spend any tax money on or raise taxes to have an all-payer claims database. In addition to that, most or many all-payer claims databases that I'm aware of are just de-identified, and you can't do much patient-centric with that, right? So to the next point, the point of care access to data. So there's a lot of talk in the previous session I was in about, well, how do we make these measures actionable, right? How do we help people do something about them? And so we provide a centralized chart on every patient that has their data from many systems pulled into one list. So one master medication list, problem list, allergy list, and so on. And that list is what the providers use in the emergency room or at the point of care, or the care managers. I will tell you the primary users of this have become those care managers and the quality officers, who go in here and try to find the mammograms that they're missing, the colonoscopies that they're missing, and so on, from all around the community. So back to this picture now. So how do we really achieve this picture and not just the stuff within Oklahoma? Because MyHealth, we end at the borders of Oklahoma. Okay, so think about us as an analogy to wherever you live, because I can tell you that there's likely to be a health information exchange in the region where you live and work. And what this map shows is a map of the members of the Strategic Health Information Exchange Collaborative. There are now 58 health information exchanges that are members, and altogether we cover more than 200 million lives in the US. That's a big percent of the country. And the map here shows the density of data. So everywhere that's dark red is over 100%, meaning a lot of people don't tell the HIE when somebody dies, so it's possible to wind up with more than actually live in a zip code or a census tract. But what you also see here is pretty good coverage of a lot of the country. And so when we took a look at this map a couple of years ago among the health information exchanges, we said, well, we need to interoperate with one another. We need to make sure that the data can move among us. And so we came up with a model we call the Patient-Centered Data Home. And the incentive behind that, of course, was so that we could better deliver services in our own communities to make sure that all the data, even if it came from out of state, was available on somebody who needed care and who lived in our state. So here's this model and how it works. So that's Western Colorado organization called Quality Health Network is their health information exchange. And those are the zip codes that they cover. They sort of claim as their catchment area. And you can see pretty good data density there. But these are the people who receive care in their community that live somewhere else. And so you can see they're probably even more than Oklahoma because they've got some great tourist sites there. And so, so how do we make sure all those green areas get their data back from Quality Health Network? Well, this is the way the model works. We take Oklahoma. This is our map again. If we have somebody from Colorado come into an emergency room in Oklahoma, we get an ADT message from that emergency room. It alerts us that the patient's in the emergency room at MyHealth. And if we open that and say, this is an out-of-state zip code, who covers that zip code, right? There's the zip code. That's in Western Colorado. So we just package up that message and push it on to Colorado. And so now Colorado is aware, the network there is aware that the patients receive care in Oklahoma. We resolve the identity of the patient in our master patient index. They resolve the identity on their end. Their local policy takes over. So if they're opt-in and they don't have an opt-in on the patient, they drop it. If they're opt-out and the patient hasn't opted out and a PCP is registered for alerts, PCP is going to get an alert that their patient's in the emergency room. The point to this, I think from a measurement perspective, is now there's an artifact in both systems that lets me know, hey, lets Colorado know there's some important data in Oklahoma. When I need to measure ER utilization, I need to darn sure make a call over to Oklahoma for these specific people who got care there, right? So that's the importance of this model. And what it winds up doing is, as people move around the country, your record follows you, right, into the place that you're living. And it can be said that your record is fully intact, especially when we cover the rest of the country. So where does that model sit today? We estimate there are about 20 million people in the United States that have data outside of their local region. And what we've done is we devised a model because we were sort of debating there were three best ways to architect this. So we had three regions stand up. One in the Heartland region, you see there in the east. You can see the western region, and you see the central region where Oklahoma is. And we took three different approaches, and we've now stood up and connected the parties in our regions so that we've got about 18, I think, or 20 HIEs connected with one another in three separate regions. And last week, the western region and the Heartland region turned on the connection between themselves, right? And now this week, we're turning on our connection to the other two, so that now we've got this breadth of the country covered with this patient-centered data home model. So we're pretty excited about this because those organizations are not doing what you're doing. They're just trying to make sure the data is comprehensive and intact and standard coded in a standard way and so on. But I'd like to encourage you to think about what you could do with data that looks like this and start to get active in sort of, you know, when you give your perspective on things, it's now possible to have patient-centric measures, I think, that are credible and that cross political boundaries as well as system boundaries. So anyway, so there's the Northeast region. We're hoping for the state of New York to come in on block and participate. And of course, the Southeast is sort of I think we've got North Carolina and Georgia there, but Florida we're still waiting to emerge. But that's okay. Each region is autonomous and governs its own components of this network. All right, so that was just to let you know this isn't hopeless. This data could become available, all right, and is rapidly getting there. The next thing is we find providers don't have a clear understanding of attribution and risk stratification, right? And so if you think about it, the people I think I'm responsible for are the people who come to my clinic and usually the last 12 months. Most EHR products, all the care gap analyses, all the quality measures run on a 12-month window because that's how the quality measures are defined, right? I mean, there are a few that go back further. But generally speaking, the list of people I'm going to be aware of are the people I saw in the last 12 months. Unfortunately, Blue Cross thinks this is who I'm taking care of, right? Because they use claims data to do attribution. Claims data run out as 3 to 6 months, and then they go back further in time. Furthermore, they attribute based on utilization and who the patient sees the most or who bills them the most, right? And other payers all have their own flavor of this attribution. Now, if I've signed a value-based payment contract with each of those payers, and my line of sight as a provider is only this list right here, how many patients am I ignoring that have a care gap that I need to close? And we see this as one of the fundamental gaps in understanding between the provider world and the payer world, right? And so we've gone to great lengths to try and make this transparent to providers, to make sure they understand the concepts behind it, but also who specifically are the patients that maybe they were unaware of previously that they were responsible for. So we have a series of these algorithms for attribution that we run in-house on the data as it comes in, and every morning we republish the attribution of patients for different reasons. And I will tell you, attribution is to me, almost a contractual concept, right? Who am I responsible for is based on the contracts I've signed. So in the Comprehensive Primary Care Initiative, I'm responsible for everybody that Blue Cross attributes to me. And in almost all these contracts have some sort of attribution logic, and Medicare has an attribution model that they use to attribute as well. And the importance of understanding that model is for the very reason I just said, which is that providers will look at the list of patients in their gap report and say, I don't even know who half these people are. And they may be right, but they're on their list because they're contractually obligated to care for them. And so we wind up putting these algorithms together and then getting them voted on in their community level governance. So we have one for primary care attribution, we have one for oncologic medical home attribution, one for procedure-based attributions, which is essentially 90 days post-procedure. The provider can see these folks in their report. And we have several others that come up as different programs emerge. Okay? So this model, just to tell you quickly how it works, says are they alive or dead? Have they had any activity in the last 3 years? Does some payer attribute them? Right? So is there a contract where a payer has attributed them? Turns out that this is the main reason payers want to give us their data. Remember I showed you a minute ago payers dumping their claims data into our system? They want to do that and in fact pay us for the pleasure of giving us their data because we run this attribution for them and make it actionable for the practices, right? So when we get that data there, in part, and we also run the measures for them too. But, and then, if the primary care provider claims the patient, and then we do touch counts. And this is one of the things that was in the CPC Plus application that Medicare put out, was a sort of a plea. The last statement was, we do attribution based on claims. If you know of any better ways to do it, please tell us how. And so we base our attribution on claims to start with, because that's what the contracts say and what's going to make the provider successful or not, and so we have to do that. But when we have the option and that decision isn't made, we base it on touches, like who has had the most touches with this patient. And we don't just count a billed visit. We count prescribed a medication, ordered a lab test, signed off on the lab result. These are all had a care management interaction. And these are things that are no-cost events that have a tremendous impact on cost and quality, because if I leave my phone on till midnight or even after midnight and take calls from patients and just call in an antibiotic for them or schedule them on Monday morning to follow up with me, instead of saying go to the ER, that's like $1,800 per phone call that's saved, right? So we wanted to reward providers who practice that way, and that was a big component of the savings in the Comprehensive Primary Care Initiative, was having those touches counted down here. And you can talk about dozens of ways to alter that touch count, but in any case, it really honors and rewards providers with stronger relationships if their touches are high, even though they may not have billed for those events. So providers can log in and see this list anytime they want. As I said, it's refreshed every morning. I've covered up the organization name, but suffice to say, here's a list of de-identified patients with their ages on it. And here's a couple of payers. So here's Blue Cross, here's Community Care, and you can see which patients they attribute to this practice. Actually, it's to a specific doctor even, cover their name. And then here are the patients the doctor claims, right? So when they send in their data, they claim certain patients in it. And then here are the frequency scores, where in this particular provider is the most frequent provider for this patient, the touch count, right? And so you can see there's some interesting patterns here, like there are a number of patients who are attributed by a payer that the practice doesn't even claim. They were even unaware. And so there's a blind spot that has to be cured, right? Here's another blind spot for a Blue Cross patient. And then one version of this report we have actually sizes these boxes so they get bigger or smaller depending on the number of touches compared to other providers. So if there's if you're way out in front, it's a big box in terms of having the most touches with this patient. If you're about to lose them to someone else, you're a little minuscule dot. So practices can actually say, okay, I've got 50 people who need mammograms and other gaps closed that I need to see them for. I'm going to prioritize the list in this way and get them in this order. So there's a little bit of strategy that practices can drive based on this. The other thing that practices have a hard time understanding is risk adjustment and risk stratification, both of those. And every payer comes to them with a different form of that, different model, different product they purchased to do the risk adjustment. And so we've had to have payers send us sort of their mechanism, and we at least try to normalize it around the same number. But we don't have a great answer for what to do with that yet, except that now we're going to deploy a risk stratification model across all our practices and hope, like our attribution model, that the payers eventually will adopt our risk stratification at a community level. Because the uninsured that don't appear in any payer's database, the dually eligible who are in 2 databases, they have a really hard time having accurate risk scores and stratifications, and would really alter what's going on in the commercial population. But we actually saw in CPC Classic, that's the first version of that model, there were several practices who saved real-world dollars in a given measure period, like they had a $50 PMPM reduction in cost, but they were credited with a loss because of a dramatic drop in the risk in their practice, because they had not coded appropriately to keep the risk scores where they were, or they genuinely had lost a bunch of really sick people. And so that was hard for them to understand and hard for them to swallow. So that's worth paying attention to. So I'll cover this really quickly just to say that one of the most important things from a provider perspective, again, is having something actionable. And something that's very actionable is to know what happened with my patient in the last 24 hours. Right? So we provide reports like this that show from this clinic's perspective all of their patients that were in one of these hospitals or emergency rooms in the last 24 hours and the kinds of data that were generated. So they know who to follow up on. So it can be said that if a practice monitors this report every day, they know everything going on with their whole panel of patients. and can do the appropriate follow-ups and so on. And then this is a 30-day readmission monitoring report, which basically says for all my attributed patients, or if I'm an index hospital, for all the people I've discharged, what's happening with those folks outside my four walls, including up to and including they've had a readmission. But you know, you can track here the outpatient visits that have occurred on this patient since they were discharged. And if I see a pattern like no outpatient follow-up, that's a red flag, right? If I see a pattern like, oh, here's an ER visit, that's probably a red flag for a pending readmission, right? So to give them tools to do something with this information has been important. And that brings us finally to, come on, the measurement, our thinking around measurement. So remember this chart, right? So if we take a measure like A1C control, right, there are essentially three things, or used to be at least, three things we focused on. And in the community, as we already discussed, with bedside A1Cs, blood pressure can be taken everywhere. They're going to have separate values in separate clinical settings, right? Each of those EHRs is going to have potentially, I mean, the patients are going to have multiple measures, but in different EHRs. And if we calculate the measures in those EHRs on these three things, were they appropriately tested every 3 months? Are they in control less than 8? Are they out of control greater than 9? These are the scores, right? Now, they're just 4 people. If I'm the payer, if I'm the government and I want to know what quality is, what do I do with this? Right? I mean, you know, the range is 0 to 100% on all the measures. And they really don't make much sense to me. Now, if I take this table, frame it in your mind, and I turn it on its side, you see the EHRs there on the left, right? So payers are going to get multiple scores on the same patient, right? And you can't roll those up because it's the same person, same 4 people counted over and over and over. So you don't have any ability to measure anything other than that clinic for the patients who got care in that clinic. And what we really want to know is we want to be able to serve other perspectives, like what's the population level of blood pressure, of A1C control? How's diabetes being managed across our community, our state, our nation, right? And so the way we approach this is when we get all the data, we resolve the patient identities, we figure out the most recent A1C for each person, regardless of where it was taken, right? And then we calculate the performance measure. And so the real answers are these, right? And it turns out performance is better than we thought on those measures, and we can do a community level perspective on it. But, and this is why I'm so adamant about talking about patient-centric measures, because we've converted that on the upper left to patient-centric measure, right? And now we can use it in some really interesting ways. And the way we use this in Oklahoma is we just figure out who's in the numerator today, who's in a denominator today, and who's excluded today on all our measures, right? And then we separate the attribution from that. We treat measurement as a person thing. You're either in, out of the denominator, or you're excluded. And then when a primary care provider says, well, I need to know how I perform, or a payer needs to know how a primary care provider performs, we just draw a box using the attribution model I just described to you around their patients, or whatever attribution model the payer prescribes, right, that's in their contract, around their patients. And so they can quickly see, well, this provider performs at 75%, and perhaps most importantly, I can see which patient I need to contact to close a gap in, right? Another payer works the same, another provider works the same way. What about specialty care? I mean, how much of the value is generated by the cardiologist versus the PCP? And what does the dermatologist bring to the table? We don't really care in this model. We just figure out everybody they touch, and then you can score how many they shared patients with, how many other providers they shared patients with if you want. But now we can know what the specialist's overall influence has been on a population as well. And then where our payers get really excited about it is they no longer have to take the average patient from every clinic. They can know specifically how their covered lives are being managed, which means that payers can do something that's really important to them, which is differentiate themselves from other payers based on what kind of network they put together and what kind of programs they put in to support the care of the patients, right? And so they can actually see just for that payer, and wherever that payer sphere intersects with the doctor is how that doctor performs from that payer's perspective, right? So in this way, the payers are looking at their own slice of the pie. I don't know if you remember yesterday, I was talking about how I've been worried that we've created a sort of an unintended consequence of the way we measure in an EHR and report that is that if I'm somebody who takes a lot of dual eligible patients or complex patients, and I have just a few commercially insured patients, the commercial insurers are not going to think I perform very well, especially compared to my peers who have young, healthy, commercially insured populations, right? And so when we now go national with a publication of how every doctor does on all these quality measures, what I didn't have before that I do now is a tremendous incentive to shed sick people, right? To have healthy people that make my numbers better. And we wanted to not have that be the case in Oklahoma, so that, you know, my performance on my Blue Cross patients now is just on my Blue Cross patients. My performance on my Medicaid patients is just on my Medicaid patients. And you can use any other number of slicers based on this same logic. So it sort of corrects that misaligned incentive, I would suggest. So then there's, of course, public health, geography. Let's look by zip code. Let's look by census tract, whatever you want to do with the measure result there. And then, of course, employers who are funding a whole lot, not all of, but a whole lot of the health care in this country, can now have a perspective on the measure that is just their company. De-identified, of course, but how is the insurance product, the payer network, provider network, et cetera, that they're paying for performing for them, which they've never really been able to get before. They've always had the claims data, of course, but not blood pressure control, not diabetes control, and so on. So one of the things we've done, because this is a little bit, I don't know, it's a little bit off the beaten path to think about measures at a person-centric level instead of in each of the EHRs people use, is to actually compare how this performs. And so this is a study we've been doing for NCQA. It was an NCQA-funded study. And what you see on the screen is essentially two major columns of measure results. Okay, this is a clinic. And what we did is we went into about 250 practices, and we ran the EHR measure, right? We pushed the button and generated their ECQM from the EHR. And we wrote down the numerator and the denominator, and we stored it in the database. And then we calculated the measures at our community level, having done the attribution and then calculating the measure, to see how did those perform. And you can see for measures that are commonly pretty good, they track pretty closely, right? But then there are some things like this measure is the brand new statin measure based on the new guidelines. No EHR products had that measure. But we could drop it in immediately, and 250 practices suddenly had it, right? Just like that. So that was one important outcome of the effort. Another one was to find out this kind of stuff happening in the EHRs. And what we found was a pretty wide variety of ways EHRs had deployed the measures. Like some called the measure window now going back 12 months when I ran the measure. Some called it now going back to January, whenever that was, the most recent January. Some let you do it on a quarter-by-quarter basis. But in any case, it was very difficult for us to align these columns on the left to compare one practice to another. And yet that's where we are as a country if we don't have some community level or patient-centric level version of measurement. So anyway, we found it interesting. We're still exploring what it means. If I showed you this picture, I can slice this picture by EHR vendor, and you'll see that EHR vendors have, like there are two vendors right now, I'm trying to track down a problem, where they've changed something about their numerator, and this is just trending down with every quarter that goes by with no new stuff coming in the numerator. And it's probably a coding thing, but we're trying to figure out where it's happened. So anyway, so that's kind of how we think about measurement. I think the battery's about to go here. Somebody on the computer maybe push it for me? There's not one up there, unfortunately. It's back in the back. It's sort of the, we're doing the Wizard of Oz thing here. There's a guy behind the curtain. Okay, so this may have gone forward too many places. Anyway, the way but then we get into the business of really having to think about the chain of evidence, right? The data that we get from our practice and how we deal with that data. Oh, thank you. Okay, go back forward one. Sorry, guys. Okay, so this is the way we conceptualize this. So if you click through it, it's a build. Next click, next click. Click, 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 click. Okay, stop there. So we've simplified it into these circles. And when we sit down with a practice, we show them this and we say, okay, this bubble on the left with data entry, your doc's got to be putting the data in the right fields. It's got to be the right coded field. And by the way, you got to sign off on bedside A1Cs, because if you don't sign off on them, they don't come out as final results, for example. And then you've got data mapping in the EHR and the data export. We're dependent on the EHR vendors for that. And you know, for the most part, that's getting better in some pretty dramatic ways, getting better. And that's really helpful that those CCDs are getting robust and that the codes are in them for a lot of things. And then the blue has got more detail because we know about it. But what we do with it is we transport the data to ourselves. We extract the data into relational tables. We transform it. We load it to our central data repository. We do some automated code normalization to fix some obvious things that we can do with logic. And then we have a manual code normalization step as well that we don't boil the ocean, but when it's a quality, you know, a numerator and a quality measure, we want to make sure we get it right. And we go through and recode that, and we collaborate with the practices to do that. And then we display and use the data in ways I was just showing you. So next click. So I already talked about these. You can build on through these. These are the things that each of those meant. And about 1 million lessons learned in how to do this, by the way. Next slide. So this is an old slide, so nobody panic. But what this shows is value sets on the left. So if you guys know your value sets, you might recognize them. And across the top are different EHR vendor products. And a dot is indicated every time we received a code from that product that indicated that value set. Okay, so don't focus on where the dots are, but focus on where they aren't. Because those are measures we can't calculate. Those are measures we got to find another source of information to support. And so when I run this today, it looks better. It's not complete. But the thing we are able to do that makes this look way better is we bring in the claims data as well, right? And those two together make a really much more complete picture on a lot of these variables. And you know, the different systems, some of them have completely rewritten their CCDs in the meantime, so that it is getting better. Next slide. This is how it looks from one practice's perspective. If they log in and choose a measure, I think this is blood pressure control. You see the value sets? And the nulls are the ones they don't have. And they have 2 locations, so this shows what we've ever received from their locations so that they can go in and fix the mapping. Next slide. And then when we present the measure results, because it's not happening inside their EHR, it's happening outside, we have to provide a lot of visibility into the logic we're using. And so you see here we have, I picked numerator and those radio buttons at the top, and I've chosen one patient on the left, and then here's a timeline with dots indicating all the value sets that were triggered over time for this one patient. And then you look at the different color coding, you can see how many organizations in the pie chart were required to get this patient in the numerator, right? But you also see how many organizations are going to get credit for this person in a numerator, depending on the attribution model, you know, whether this patient's attributed to them or not, right? And this really opens the eyes of the providers, almost more than anything, for them to see how dependent they are on other people they refer to or sometimes that they don't refer to. In fact, there's a heart clinic that has got absolutely both the best process around smoking and smoking cessation and the best documentation that gets all the way through to us with the right codes. And so primary care providers have just started referring there to make sure they're going to get credit on all their smoking measures. I mean, it's a really, for the first time in my experience, it's an opportunity where actual evidence and performance can drive my decision about where to refer a patient, right? And that's something I think is a positive thing we can achieve. Okay, next slide. Another thing about quality measures, next slide. There you go. Another thing about quality measures, as you guys know, is that they're really complex. And so we try to expand out the logic in the measure so that you can see each step, and the provider or their data person, whoever their quality officer is, can click on each of those circles and zero in on the patients in those circles. So if there's a particular exception that's a problem for them, maybe it's just a data issue that's dropping people into an exception, they can figure out where they're losing folks, and they can get them redirected. We get a new battery? Oh, thanks. Okay. So the way this works is if I click on here, so this is everybody. What is this? All-cause admissions, readmissions. So this is everybody. This is the ones that got admitted. These are the ones that walked out the door AMA. Very tiny bullet, but it's one of the exceptions, right? All the way down until I have my denominator built, and I can look at who's accepted and who's kept in all the way to the numerator. Just the idea is that we have to build trust with providers. They have to trust that these measures work. We usually only ever have to take them through this once for them to know we understand what we're doing and we've got their back. You know, we're not going to expose them to some unnecessary measurement or some bad process, but we do have to take them through this. Am I too far away? Is it the metal in my mouth? That work? Oh. Okay. So you remember this. Now we're to the point where this really matters a lot, right? Because it's the end of the year. We've calculated the quality measures, and some of them really suck, right? Like diabetic eye exam, for example. Nobody does well on that. And yet it's one of the 7 measures that all the payers have agreed on for the Comprehensive Primary Care Initiative. So we package that measure up. We show a generalized across the community score. And because of the comprehensiveness of our data, we can show our own benchmarks, right, about how that performance looks. And nobody does well on it. And when we present that to the payers, at least every time we've done it up to this point, they'll say, yeah, throw that one out. You know, but if any given practice went to the payer, they wouldn't throw that out. But as a trusted third party in the middle, we have some credibility that we don't have a dog in this hunt. Next slide. So we are able to show benchmarks like MIPS benchmarks and calculate the score. Next slide. It's hard to read from where you are, but if we mouse over, if I pick the benchmark I want to hit on the measure, I can see both what's my target and how many more people do I need to treat to get to the next level. Right, to the next target. And you see the little blue link there. If I click on that blue link, next slide, now I've got the list of people that are my potential targets for this measure. And each column is a different measure, so I can do that. Next slide, please. And then, of course, we can show if they're on track or not by showing all their measure events over time and trending those to see if they're filling the bucket with enough mammograms, they're filling the bucket with enough blood pressures in control to hit the target they're on. And this is what I mean, at least, when I say actionable measures that I can do something with. Next slide. And so, I already mentioned MIPS and scoring for that. Now, we do find still that payers will want to have their own benchmarks for things. So we've got the MIPS benchmarks out there, and then we've got this other set sometimes from payers. Next slide, please. And you can build that whole thing. So it calculates scores, and what we found is a surprising number of practices actually scored well already based on the data we had from them. Next slide. Oh, next slide. So one of the things that our organization has done is be qualified as a QCDR, Qualified Clinical Data Registry, so that we can submit these results on behalf of those practices. And I think that that's a positive thing because we can run all 3 kinds of measures. We can run EHR-derived measures, we can run claims-derived measures, and we can run registry-derived measures as well. And you'll see, next slide, that that's kind of important. So these are the benchmarks for A1Cs. Okay, A1C control, right? And this is a golf measure, so lower is better. So what you see over here in the 90th percentile, if I want to hit the 90th percentile reporting for my EHR, I can have fewer than 3% of my patients out of control. That's tall cotton. If I'm using a registry like what we provide, I can have 17% of my patients out of control and still be considered 90th percentile, right? I'm not sure we understand why these different benchmarks are out there, why they're so different, but they are. Next slide. So here's cholesterol control. Out of the EHR, I've got to be at 65% or 60% to hit the 90th percentile. But out of a registry, I've only got to be at 6% or 7% to hit the 90th percentile. So this is the kind of thing going on in the heads of the providers that are actually using these measures to try and figure out how do they appear on that national web page in a listing at all 90 percentiles or at the maximum that they can get. And so most doctors, they're pretty intelligent folks and they want to win the game. And winning the game means being on the right end of this chart. Now take a look at the next one. Next slide. So you can see they're pretty close on blood pressure control, but the advantage is to the claims-based calculation of blood pressure. That's a mystery to me. But the specification is out there, but somehow people are attaching their blood pressures to, I guess, G codes or something? CPT2s must be. Next slide. And then this is breast cancer screening. Again, advantage this is lower is better, right? So advantage to EHR here, right? So the point is, I think over time, this is hopefully just the only year we're going to have benchmarks that look like this. And hopefully the first year of MIPS reporting will be used to reset benchmarks because I suspect these were all set based on the PQRS model where people self-reported. And I don't know if you've ever looked at the benchmark for eye exams, diabetic eye exams, to come back to that measure. It's like 95% to hit the 30th percentile. And the reason for that must be, this is my own hypothesis, that only optometrists ever reported that measure. And they do eye exams on everybody. So anyway, thank you guys very much for your time, and I'm happy to stay around for questions after. Yeah, sure.